So the Shona people of Zimbabwe and southern Africa, they honor traditions of greeting. It's a very important ceremony when you greet another there, and they have ritual greetings. The morning greeting is this one, Marara Se. That means, did you sleep well? And the traditional response is Ndadara Kana Marana Wo, which means, I slept well if you slept well. We'll come back to that. This talk is dedicated to two people, Sir Michael Marmot and Alan Kurdi. They never met. Now they cannot meet because Alan Kurdi died. We're going to talk about Alan Kurdi a little bit later. But Michael Marmot is very much alive. He's one of the leading epidemiologists in the world today. He directs the Institute of Health Equity at the University College London. Sir Michael has been working on health inequalities for 40 years. His work is the basis for healthcare policies all over the world. Now you can leave. You can skip the whole rest of this talk. You can go out and take a good walk, which will be better for your health. As long as you do me one favor, I need you to buy and read Michael's latest book. It's called The Health Gap. I get no royalties. But it's one of the most important books I have read in a decade. So go ahead, buy it. I won't mind if you get on your phones right now and buy it online. Or better still, the bookstore, this is true, is staying open after my keynote because they've stocked up on this book, and maybe on your way out you want to pick it up. You will thank me if you do it. And in honesty, the rest of my talk just plagiarizes Michael's book, which is why you can all leave. So Michael introduces us to an unfortunate 15-year-old boy. He calls him Andy. And Andy's a pretty normal guy, but his future is quite worrisome. You see, Andy wants to live as long as he possibly can, but he drew a short straw. And that's because of where Andy lives. Because of where he lives, the chances that that 15-year-old boy is going to live to see his 60th birthday are lower than in 49 other countries. If Andy lived in Sweden, he'd have over a 93% chance of living to age 60. But Andy's chances are 6 percentage points absolute lower, 87%. That's lower than Costa Rica, it's lower than Cuba, it's lower than Slovenia. What is Andy's short straw? Here it is. He lives in the United States. In 2013, the National Academies of Sciences report compared the health of my country, the US, to health in 17 other developed countries. Life expectancy at birth, chances of living to age 50 or 60, death rates from over 200 diseases, and we do not look so good. In fact, that's putting it mildly. We look awful. We are 17th out of 17 on outcomes that really, really matter. For 40 years, Michael Marmot has been trying to find out why. Why does the burden of disease vary so much, even among countries that look similar? Why does it vary among populations in the same country, even in the same city? Why, in 2002, when you got on a bus in Glasgow and you traveled west to east for just 3 miles, did life expectancy fall by 28 years? In the west of Glasgow, you would live 82 years. In the east, you would live 54 years. Glasgow may be one of the worst cases of what we call the subway map view of health status, but it's not worse by that much. This is the London subway map. You travel 10 miles from Oxford Circus to Star Lane in East London, and life expectancy drops by 21 years. In Chicago, the delta is 20 years. Amona Hana Atisha from Flint mentioned that within the city of Flint, Michigan, it's a 15-year subway gap. My friend and colleague Ben Collins, a young researcher at the King's Fund in London, has written a phenomenal report on Montefiore Health System in the Bronx in New York City. Second recommendation, get this report. It will open your eyes to what is possible. Let me read Ben's words. This is verbatim from his report. Stay with me. He says, every day in New York, the D train running from Coney Island to the Bronx achieves an astonishing process of social segregation. Picking up the D train in Midtown Manhattan as it crosses 85th Street, running alongside Central Park, the residents of the Upper East Side who are walking above you, they have an average household income of $180,000. Smoking, obesity, chronic disease rates are well below the national average. Life expectancy at 85th Street is 85 years. That's better even than in Japan. By the time you cross 165th Street, which is the heart of the South Bronx, almost all of the white people and all the suited professionals are not on the train. They've gone. The average household income has shriveled from $180,000 a year to just $45,000 a year. Unemployment has doubled in the South Bronx. 65% of the kids are born into poverty. Between 85th Street and 165th Street, Ben writes, life expectancy drops by a decade. 6 months for every minute on the subway. 2.3 years for every mile traveled. Now you could pick your city. In most countries, and including most cities in the US, the subway map is going to tell you the same story. Years, decades of life lost within just a couple of miles. 6 months of life lost for every minute on the train. So how big a number is that? It is enormous. Marmot did a calculation in his book, a back of the envelope calculation. He asked a question. How many years of life would be gained if, by magic, we eliminated heart disease on Earth? Not treated heart disease, eliminated heart disease. And the answer is, on Earth, we would gain 4 years of life. The gap on the D train is 2.5 times bigger than the entire burden of heart disease. The gap in Glasgow in 2002 was 7 times bigger than eliminating all of heart disease. I mean, look, aren't you happy about the miracles of modern medicine? I am. Take one miracle, statins. Statins may probably do delay or prevent some cardiac deaths. Now, it's a bit controversial, but let's take the most optimistic trial published on the effect of statins in the literature. If you take that trial, the average gain in lifespan is 1 day of life for every year of statin treatment on average. If you take statins for 20 years, then on average you're going to gain 20 days of life. Traveling on that D train, that amount of lifespan, 20 days, evaporates in 7 seconds. On the Glasgow bus or the Chicago bus, you lose 20 days of lifespan every 43 feet. Is that poverty? Well, poverty is a killer, no doubt. Grinding poverty, the dollar a day kind of poverty that 1 billion people on our planet or more still suffer from. Between the richest countries in the world and the poorest, life expectancy differs 35 years. In 2015, the life expectancy in Japan was 84 years. It was 50 years in Sierra Leone. But that does not explain the Glasgow or South Bronx or Chicago does it. They don't have dollar a day poverty, not dollar a day poverty. So Michael Marmot is a scholar. He starts with the data. He uses proper inference. He doesn't use political polemics. He unlayers the truth like an archaeologist exploring an ancient site with his stratum by stratum, with a tiny brush and a toothpick in his hands. That's what you find. It takes a whole book to summarize what he says the evidence says, but I'm going to put it in a nutshell. You still buy the book. The bookstore will be open after this lecture. So Marmot, among his many other achievements, played a pretty big role in 2 famous studies in England. They're called the Whitehall studies. Whitehall refers to the seat of the national government in England, the buildings in London where national civil servants work, security guards, clerks, janitors, mid-level managers, executives, deputy ministers, and so on, all the way up to the highest level officials in big wood-paneled offices. The White House studies followed about 30,000 of these civil servants for decades. They tracked their risk factors and their outcomes, their disease status. And there, Marmot and his colleagues found what is now called a social gradient for outcome. And here's the basics. The lower your job grade, the higher your rate of disease, and the shorter your life. And listen to this. Interestingly, that gradient operates all along the social spectrum, from the very lowest job grade to the very top. No matter where you are on the social hierarchy, you're better off than the people below you and worse off than the people above you. And even more curiously, although the usual risk factors, cholesterol, blood pressure, obesity, and so on, they vary the same way. The lower your job rank, the worse your risk. Those risk factors do not account for the gradient in outcome. Not even close, they only account for 1/3 of the differences. Something else is going on, and Marmot is trying to understand, well, what is it? So here's the simple answer. It's social determinants of health. But what does that mean exactly? What determinants? Of what health? Whose health? Why? How? And answering those questions, that's Michael Marmot's project for 4 decades. Now, one thing is for sure, you already know it. Those social determinants of health, they are monsters compared to what we throw at health with healthcare. Sure, healthcare has done miracles, and I don't want to gainsay those. AIDS drugs, organ transplants, cancer therapies, amazing, and we should never give any of that up. That's not what I'm arguing for. But whatever's at work in East Glasgow or West Chicago or the South Bronx, it's much, much more powerful. Remember that, 20 years on a statin versus 43 feet on a bus ride. The gap can be closed. Nepal's an interesting example. In Nepal, between 1980 and 2012, life expectancy rose by 20 years. That's 2/3 of a year of life expectancy gained per year over 30 years. 16 hours of life expectancy gained in every 24 hours over the past 30 years. That's not bad. So something can be done. Health status can change. So I have bad news, I have good news. The bad news is this. There are massive gradients in health all around us, and absolutely in the US. Treating illness is important. We never should give that up, but nothing we can do with treatment, nothing, can change those gradients, nothing. You can spend the rest of your life, you can spend all of our money on healthcare, and you will not produce health. You cannot produce health. This is not a healthcare problem. That's the bad news. The good news is health can change. See Nepal. How? So scientists hunting for the causes of the Whitehall effect, lower status, lower health, have come to some pretty strong conclusions. And this is science. Marmot, in his book, explains that. He digests it, and he explains 6 categories of cause. He calls these the causes of the causes. And so, to some extent, when you say social determinants of health, this is what the science says you should mean. I'm not going to claim Marmot is covering the whole territory, and there are other determinants that we're not going to recite, but I'm going to tell you his viewpoint. But I warn you, it's all going to cycle back to inequity, uncomfortably so. As Marmot puts it, inequities in power, money, and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health. That is not politics. That is science. If you want to reduce health disparity, if you want to improve health, you have to reduce inequality. So I'm going to take you through a little bit of that journey. It's got pretty wonky for a little while, if it isn't already. I'm going to take a closer look at what matters with Michael Marmot as our guide. First, early childhood matters. Here's Marmot's words. What happens to children in their early years has a profound effect on their life chances and hence their health as adults. One measure of what happens to kids is the index called Adverse Childhood Experiences, ACEs. ACEs were first described, by the way, at Kaiser Permanente, a strategic partner of IHI. A child's ACEs score is it's the number of yes answers that the child can give to a specific list of stressors. Stressors like fear of physical or psychological abuse, witnessing violence, being exposed to alcoholism or drug abuse in the home. The predicted value of even a slightly elevated ACEs score for adult health is absolutely astonishing. People with 4 or more exposures as kids have 5 times the risk of recent depression. They have 12 times the risk of attempting suicide, when they are 15 times more likely to have learning disabilities. When they get to be adults, they have much more cardiac disease, much more lung disease. They are 5 times more likely to engage in substance abuse. Now, if that's the score, among nations, the US ranks really poorly on childhood well-being. For many kids, I must say, American society is an ACE factory. UNICEF reviewed child well-being in 21 countries, material well-being, educational, behavioral well-being, at-risk circumstances in 21 countries in 2013, and the US ranked last. If you invest in kids, as the Scots know, the health of the population improves. That can be done with social policy. Here's how financing child well-being looks in 35 countries. It shows, it's complicated. You can look it up on the UNICEF website, but it shows how child poverty decreases in response to public policy on income transfers. The US ranks worst in fighting child poverty, except for Romania. Are you starting to hear a theme here? This is where the Scots started. You heard it from Jason and Derek. The Children and Young People Improvement Collaborative, formerly known as the Early Years Collaborative, it aims to break the cycle that gave us the Glasgow map by focusing on making Scotland the best place in the world to grow up. It may take a generation for them to see the full effects, but there's some early signs of success already. Increased access to financial advice for pregnant women on low incomes, helping to increase income by up to £5,000 per family. An early focus on healthy pregnancy, which I've had some view of now, has reduced stillbirths in Scotland by 20% in just 3 years. Early childhood matters. Second, education matters, especially education of girls and women. Educational attainment correlates very strongly with infant mortality rates and with life expectancy. These are the data for the US now, I think 2008, between the lowest and highest education, a 10-year difference in length of life. Of course, that's just a correlation, not cause. Could it be that poor health leads to poor education instead of the other way around? Well, it could be, but it's not. Education improves health at any income level. Preschool education is particularly powerful according to the science. I'm going to take you into the weeds further for just a minute. This is a very complicated chart. I apologize for it, but it's interesting enough for me to explain it to you. It shows how the amount of education you get relates to life expectancy in 15 countries. So the bottom of each of those vertical bars is low education life expectancy. The lowest education life expectancy, and the upper end of the bar is the higher education life expectancy, and that's where you see that 10-year difference. In Estonia and Hungary, it's even bigger. It matters a lot. 15 years of life difference between the lowest and the highest educational achievement. But a number of countries, like for example Portugal and Finland and Sweden, they've eliminated the disparity. In those countries, your life expectancy is high no matter what your educational level is. And that is because inequity really, really matters. The countries that invest in reducing inequity abolish the relationship between educational attainment and life expectancy. Third, work matters, the conditions of work. Some of it's obvious, like levels of pay. Marmot uses a term that I think we all should begin to use. It's called minimum income for healthy living. That was created by famous UK epidemiologist Jerry Morris. Here's Morris's definition. He says, a minimum income for healthy living includes not just what is necessary for food and shelter, but what is required to live a life of dignity and to take one's place in society. That's a different definition of poverty from the one we use. Denied to an old person enough money to buy a gift for her grandchild or to take a bus to a social gathering, and you will harm her health. She will die sooner. In the US and elsewhere, income and wealth inequalities have soared to a point now where many, many people, many hardworking people, people we wouldn't call below the poverty line, just cannot afford the things that bring them dignity and meaning like that. And other properties of work matter too, not just pay. Toxins and exposures matter. So does a sense of control over your life at work, social isolation at work, a sense of being treated fairly. Unemployment kills. In one study in the Czech Republic and Poland and Russia, after 6 years, unemployment doubled the death rate in men and women. Loneliness is a killer. In a study at University College London, people who were socially isolated at the start had double the risk of developing coronary artery disease compared to those who didn't. You don't see deltas like that, coronary heart disease risk varying by 29% increase, stroke increase, 32% based on anything we do with medicine. That's loneliness. Fourth, the way we deal with aging matters. Terry's been really the nation's leader on that argument, but it's a bigger effect than even Terry would say. How a society supports and cares for its aged doesn't just affect the aged. It affects the entire community. One thing that helps is to give elders a chance to stay employed in useful work. By the way, Marmot blows apart a myth. It's the myth that if you keep older people at work longer, it denies work opportunities for younger entrants. That is dead wrong. Marmot's finding is, in general, the higher the participation of older people in the labor market, the higher the employment rate for younger people. This is all about empowerment, all about what you heard in Maureen's keynote panel. It's giving people the chance to be active and the chance to stay connected, the chance to participate in society. There was a meta-analysis of 148 studies of people over age 64. It found that if you followed them for 7.5 years in that study, people who were socially engaged had a 50% lower chance of dying. Fifth, the resilience of communities matters. The evidence is very strong that if you give local communities, places, a chance to control things, then they come up with really powerful approaches to changing the factors that affect health and well-being. I've learned that through Shoma Stout and the work of the 100 Million Healthier Lives campaign better than any other way so far. Communities that feel self-efficacy, that feel powerful, have better health. Professor Christopher Lalonde in British Columbia, he studied suicide rates in indigenous communities, which are extremely high. But Lalonde found they weren't always high. Communities that were able to hold on to their cultural history, promote their own collective future, they had markedly lower suicide rates. And the opposite of that is social exclusion. And we've already seen what that can do. So in summary, this is Marmot's prescription for community resilience. What happens at the local level can contribute to crime and alcohol-related deaths and obesity and road traffic accidents, injuries, depression, health problems related to pollution of air and water, problems with housing. That's the deficit-based view. But on the plus side, using an asset-based view, the local level can improve health through high levels of social cohesion and social participation, security, a low fear of crime, active transport, provision of green spaces, walkability, availability of healthy food, good services. Remember, all the effects of statins and 43 feet on a bus. That's about the community. That's Marmot's list. I've condensed it so far. The first 5 things: if you want health, then work on the causes of the causes, early childhood experiences and supports, education, especially for women and girls, the conditions of work, pay, security, unemployment, meaning, respect, a sense of control, and the experience of aging, which affects everyone, and the resilience of communities, especially local control and local solutions. But we're not done. Marmot has one other item, a sixth item on his list, and he says it is fairness, fair societies. Since inequity matters so much, it's the cause of the causes of causes, he cannot escape the question, and Marmot does not try. He's a courageous guy. He just says, what, after all, would lead us to invest in the reduction of inequity? And after all, some countries do and some countries don't. And in the countries that reduce inequity, people live longer. It's a pretty stark question he's putting to us. It's a question about the kind of communities that we want, the kind of nations that we want, the kind of world that we want. It's a test of our honesty. Do we care about each other or not? To use Derek's frame, are we a community of purpose? If a man from Mars showed up, he would probably have some pretty serious questions about, I'm giving a speech. He would probably have, oh, okay, excuse me. Oh my goodness. Oh my goodness, excuse me, ladies and gentlemen. I have just gotten the most extraordinary news flash. I mean, today, right here, right now, our AV technicians report they've made contact with, wait for it, a man from Mars. How amazing. Right here, this is the first ever contact with an extraterrestrial. I'm sure you won't mind if I interrupt the lecture. We'll get back to it to just have a quick chat. Hold on a minute. Hello? Hello? Are you there? Can you hear me?
Yes, I can hear you. Can you hear me? Why are they laughing?
Oh, don't let them bother you. Yeah, I can hear you loud and clear. This is really exciting. Can you please tell me your name and where are you calling from?
Yes. I am calling from Inkablatten, which your people call the planet Mars. I am called Justin Bieber, after one of your species.
Oh, and you speak English? And you know about Justin Bieber? That's amazing.
Yes. We love Justin Bieber. In fact, in his honor, I have many of his, how do you say, tattoos. I can disrobe and show them to you.
No. That will not be necessary. I'm sure your tattoos are very nice.
We have been watching you for quite a long time, and we wanted to say hello.
Oh, that's nice of you. And why, may I ask, have you decided to contact us after such a long time, Mr. Bieber?
Oh, call me Justin.
Oh.
It is because we want to improve our health on Mars, and we thought you might have some suggestions. Also, IHI seems so cool. Many of us will come to your next national forum. We will try to blend in.
That'll work, yeah. Well, I'd be happy to help you, Justin. Can you tell me a little more?
I will have to be quick. I'm getting a low battery signal. But briefly, we live here on Mars about 1,000 years, Martian years, which is 1,882.14 of your years. But we have an improvement project. We want to double that. So how are you doing? You got anything for us?
Well, actually, we only live about 75 years on average. We are trying to improve that.
So how are you trying to improve that?
Well, we build hospitals. We train doctors. To treat diseases. We have lots of machines. We have lots of drugs.
No. You don't understand my question. I am not asking about your repair programs. I'm asking about how you stay healthy.
We put $3 trillion a year into what you're calling repair, Justin. You should see all the cool stuff we have. I mean hospitals and machines and robots. And,
That's nice, but can we talk about health? I mean, how much do you put into health?
Well, I'm not quite sure.
Well, estimate. Is it like $3 trillion? $10 trillion?
Oh, no, nothing like that. Where would we find that kind of money, Justin? Maybe on Mars, but not on Earth.
I thought you said that you found $3 trillion to fix things after they are broken. Why would you not keep from breaking them in the first place?
Well, it costs too much. It costs too much.
I think we have a bad connection. Did you say it costs too much? Is that like an Earth joke?
No, I'm serious. No, it does cost too much. After all, and it's not our job. I mean, that would mean fixing housing and schools and transit systems and prisons, addressing income inequality. We can't do everything, Justin.
So you would rather do repairs? May I please use an English colloquialism? Are you nuts?
No, we're not nuts. We're logical. I mean, it's just. It's
My battery is getting really low. I think maybe I should get moving along to another planet. I will use a traditional Martian farewell. Upsy dupsy.
Oh, that's like Spock. Does that mean like live long and prosper?
No. It means get back to me if you get a brain.
Well, no. Look, don't go, Justin. Tell me something I can use. I mean, how on Earth or how on Mars do you live to be 1,000 years old?
It is not rocket science, Earthling. We work on causes, not just the consequences. You should try it sometime. Over and out.
What a rude dude. I mean, where does he come off telling us that we're wasting time? Get a brain? I mean, really. Now, where was I? Oh, yeah, social determinants of health. I guess I was asking a rude question myself. I mean, do we mean it? Or don't we? Let me be absolutely clear. If we mean it, when we don't just wave our hands at real social determinants, when we act on them, it works. Not just in Nepal. That's not a theoretic statement. It's empirical. I'm going to give you 6 examples of what it looks like to work on social determinants. Try, for example, Eastlake, which is a neighborhood in Atlanta, Georgia. This is one of 22 so-called purpose-built communities. That movement was started by a philanthropist and real estate developer, a guy named Tom Cousins, with whom I've spoken. Tom came across a fact that he just couldn't get out of his mind. It was a Rutgers University study, and it showed that 3 out of every 4 inmates in New York State prisons came from just 8 neighborhoods in New York City. 75% of all the state inmates in New York from 8 neighborhoods. And so he set out to fight that form of destiny, the destiny that your place is your fate. So purpose-built communities like Eastlake, they're neighborhood-based. Eastlake has 175 acres, it's 542 apartments, 2,100 students. And with some grant support and public and private investment, a stakeholder table, what they call a quarterback organization with schools, the Housing Authority, the YMCA, more, they tackled the housing supply, the food availability, parks, recreation, the health coverage. Eastlake started in 1995, and here are the results. 90% less violent crime. Welfare dependence is down from 59% to 5%. Unemployment of the non-disabled, non-elderly in Eastlake is 0. High school graduation rates went up from 50% to now 97%. They work on housing, on economic stability, cradle-to-grave education, public health and medical care, neighborhood and physical conditions, and community bonding and resilience, and you don't have to be Scottish. I should mention, by the way, that right here in Orlando, two health systems, Florida Hospital and Orlando Health, they've signed on to the Purpose-Built Communities program. They're working with Lift Orlando, the quarterback in Orlando, revitalizing the West Lakes area of Orlando, sparking $100 million of investment, helping with an early learning center and a health and wellness center. Second example, take a look at Community Medical Clinic. That's a free clinic in Kershaw County, South Carolina. They aimed at reducing emergency room dependence, emergency room visits by targeting social determinants. They started a school-based health center, 4 satellite clinics and churches. Non-elective ER use fell 25%. They targeted high school graduation rates. Graduation was the best single predictor of long-term health status. Remember that association from Marmot's book? Beefing up mental health services, sports physicals, social supports. They train youth ambassadors in quality improvement methods. Graduation rates in Kershaw are now 84%. They're going to be 94% in 2020. A third example, the Cleveland Foundation and Living Cities. They brought together anchor institutions in Cleveland. This include university hospitals, Cleveland Clinic, Case Western, to transform their core operations. And the theory here is buy local, live local, hire local. Change where the hospital purchases from, where they incentivize their employees to live, where they hire from. These hospitals and other anchor partners have invested over $500 million into the 7 poorest zip codes with the worst health outcomes. They've created 1,800 jobs, more than that. They've leveraged $4 billion of additional investment just by conducting their normal business there. More importantly, 1,800 residents have been actively engaged in proposing and funding their own solutions, community resilience, through an innovation program there called Neighbor Up. That helps build leadership in the community residents and supports groups of residents to develop solutions that are then funded by mini grants from the Cleveland Foundation. A fourth example, similar, you heard it here from Dr. David Ansell at Rush, if you were in the CEO summit yesterday. So Rush University Medical Center in Chicago, it's also taking the role of anchor institution in Chicago's West Side. They have produced a phenomenal playbook about what it means to be an anchor institution. I think, by the way, the anchor institution playbook from Rush, that should also be required reading. I've told you to read Barnett's book, Ben Collins' King's Fund paper, and the anchor institution playbook from Rush. It should be required reading for every hospital executive and every board in the United States. The tactics include local hiring, local sourcing, local construction, impact investing in communities, and support for affordable housing. They started with their subway map. A resident in the Chicago Loop lives today an average of 85 years. One in West Garfield Park lives at 69 years, a 16-year gap. And they formed an alliance called West Side United with 5 other Chicago area health organizations, 100 community-based partners, and they aim to cut that life expectancy gap by 50% by 2030. I hope they do it sooner. This is a key idea from the Rush playbook that gives you an idea of what anchor institution means. Here's what they say. When hospitals and health systems nationwide together spend more than $782 billion a year, employ more than 5.6 million people, they hold investment portfolios of $400 billion. The potential game-changing impact on health and well-being in America's communities cannot be overstated. They're taking their economic and physical presence and converting it into an asset for community-based resilience. A fifth example, this is outside our country. I visited just a few weeks ago the health system in Gloucestershire, England. The National Health Service there is working through a new group of organizations called Integrated Care Systems in England that we're going to study. It's working with a nonprofit community-based third sector organization called Treasure Seekers, and it helps people with severe mental illness, people constantly bouncing in and out of emergency departments and police stations. And they now run a place together called The Cavern, which Treasure Seekers started. It's a drop-in center. I was there, I visited it. It's open 365 days a year. It has a coffee bar, which employs the people they're trying to help. It has a music stage where concerts are every night with music being played by the people they're trying to help. A living room for 700 people with mental illness. I met a police constable in the Cavern who said to me that people who used to be in her police station 5 times a day are now never there, and she could tell you their names. Hospital admissions and emergency department visits, they plummeted. People who were lost and lonely now have a home base. A sixth example, the one I started with, Montefiore Health System, the documented by Ben Collins in the King's Fund. It has a 40-year track record at Montefiore of engagement of the type we're talking. 40 years of engagement with social determinants in a really stressed part of the city. And that's no small organization. It's 32,000 employees. It serves a population of 3.5 million people. Their programs on Marmot's causes of causes are endless. They use navigators in their emergency department to spot people who are at a very high risk of return and further trouble. They use post-discharge calls for everybody within 48 hours of discharge to identify unmet needs for help. They have teams. They have teams dedicated to housing, teams dedicated to nutrition, teams dedicated to pharmacy support. I've met these teams. I've seen their work. They maintain and use high-risk registries. And screen for social needs, just like they would screen for physical threats. Bottom line, this place doesn't wait for trouble. They use every tool they can to anticipate and intercept trouble. They target the highest priority neighborhoods. They use heat maps. Everything they do in partnership with community leaders, with communities, not to communities. I want to give one other small example. My wife, Ann, works now for the city that we live in, which is Newton, Massachusetts. Ann is sustainability director for Newton. She works all the time on making it a green and sustainable city. She told me about a meeting that she had attended just a couple weeks ago with her boss. Her boss is the mayor, and this is the mayor's cabinet meeting with department leaders. The mayor is Ruth Ann Fuller, just elected. Mayor Fuller had come across a New York Times article that showed the evidence that the future of a child was determined largely by the social conditions of the local neighborhood where he or she grew up, related, of course, also to race and racism. The place was your fate. I guess you could say Mayor Fuller discovered Michael Marmot's book, although I gave her Michael Marmot's book. The bookstore, did I mention the bookstore will be open? Mayor Fuller did something really simple that just caught my attention, and I put it in the speech. She asked her planning department to draw a map of Newton that showed exactly where the social risk and the poverty were concentrated. This is Newton's subway map, so to speak. Newton's a very wealthy city, but it's unevenly wealthy. So 2 neighborhoods lit up. You can see them there, the yellow and the green. And Mayor Fuller, in front of her cabinet, pointed to those places with her laser pointer and told her cabinet, from now on, whatever you're doing, fixing potholes, planning services, repairing a school, drawing a bus route, whatever you're doing, she said to her cabinet, from now on, start there. Start here. Start here. That, to me, that's the 2-word charter that answers the tough questions of the man from Mars. Start here. Start where the causes of causes lie. Start where the plague of inequity and social isolation hides and writes its tragedies. That is a big idea. That's not a small idea. It wakes us up. It wakes us up with one deeply uncomfortable question about who we are, who we wish to be. Are we one? It's the question that Father Boyle asked us this morning. Two days ago, the Universal Declaration of Human Rights celebrated its 70th birthday. It says at the very beginning, Article 1, all human beings are born free and equal in dignity and rights. They are endowed with reason and conscience, should act toward one another in a spirit of brotherhood. Are we one? Do we care? In this vicious, unconscionable time in America, a time when our leaders have the audacity, the meanness to divide us and make us fear each other, we have a moral obligation to say no to that meanness, no to that division. We have an obligation to insist on compassion. We have an obligation to insist on solidarity, to insist that we are one or we are lost. This is not just about health, of course. It's about peace. It's about a livable planet. It's about a future for my grandchildren. Do you sleep well? I sleep well if you sleep well. I said that I dedicate this speech to 2 people, Michael Marmot and Alan Kurdi. Actually, you already know Alan Kurdi. He's this child, in what is now one of the most famous photos of our generation. 3-year-old Syrian Kurdish refugee whose little boat capsized on the way to freedom and whose body washed ashore on the coast of Turkey. The social determinants of health killed this little boy. Forces of fragmentation and self-interest, political ambition and economic inequality, neglecting the least among us in the service of what? Forces far, far more powerful than any germ or any gene killed this little boy. Forces far, far beyond the reach of the medical cathedrals that we have built. Forces that need to change now. This death is our death. Who can see this and still sleep well? We can walk away. We can say, not our job. I can't do everything. Just work here. They don't pay us enough. I can't go to the margin, like Father Boyle told us. But if we walk away, make no mistake, there is no honest harbor in the claim that we cannot do anything about it. That is a lie. Kershaw can, and it does. Eastlake can, and it does. So does Montefiore, so does Rush, so does Gloucestershire, so does Mayor Fuller with her laser pointer, her leadership, and her instruction. Start here. Walk away if you have to, but if you think it is time, and I say it is time to get real about what tears apart our health and our future, I've got a few start heres for you for next Tuesday, right after you finish reading Michael Marmot's book. So first, start here. Start by signing up for the IHI-sponsored project called 100 Million Healthier Lives. While you're there, just take a look, by the way, at their Pathways to Population Health Initiative. It's everything I just said. You just sign up, just do it. You will join their almost 2,000 organizations that are dead serious about the causes of causes. You will meet folks from Kershaw and Eastlake and dozens of others who won't quit. Join us. Second, start here. Contact purpose-built communities. Become one. Healthcare organizations have not generally stepped up here. They have not become the hosts and sponsors they should for this phenomenal program. Change that. Be a leader for purpose-built communities in your neck of the woods. Third, start here. Find or create the map of deprivation for the area you serve so you know where to start. Copy Mayor Ruth Ann Fuller. Get together with your staffs and your departments and your partners, like Montefiore has and Rush has, and aim your laser pointer at the spots where the beasts of causation, the causes of the causes, hide, and say, hey, everybody, start here. Fourth, don't do this to communities. Do it with communities. Susan Edgmond-Levitan and Maureen Bisignano now famously have taught us always to ask at the individual level what matters to you. Now we need to do it with communities too. We will not produce health for communities. We will only do so ever with the communities. Fifth, start here. Starting now. The Cleveland and Rush anchor institutions' commitment to buy local, live local, hire local. They add vitality and resilience to the communities that they are in. You can too. Get the Anchor Institution playbook. Speak to Dr. David Ansell if you want some guidance. Read the playbook, use it. Check out the Democracy Collaborative's hospitaltools.org, hospitaltoolkits.org, which is a guide to how to do this. And join, there's a network called the Healthcare Anchor Network. Join it. Join it. Sixth, develop a resource base, a knowledge base about the resources in your community that it already has to address social determinants. Ask Jason and the Scots how they did that, linking to municipalities and the resident resources, not going in to rescue, but to join. You can find websites to help you too that are really helpful, are Aunt Bertha, auntbertha.com, and Health Leads. That's what they do. They're ready for your use. Seventh, you move from reaction to prediction. Who's likely to get into trouble? How can you help them stay away from that edge? Follow what Gloucestershire did with the cavern, or what Montefiore does with its navigators. Eighth, start here, start with the Scots. They started and invested in early intervention. Make your community the healthiest place in your state or in the nation to grow up. You can get ideas at the website on the Improvement Collaborative in Scotland, but do it yourself. But most of all, we've got to heed Michael Marmot. Inequalities, inequities in power, money, and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health, the causes of the causes of the causes. We cannot achieve health and accept vast inequity. That is a bankrupt idea. And if you doubt it, remember Alan Kurdi. The image of that little boy, it's just going to haunt me every day I live, every time I look at one of my grandkids. He didn't build the boat or create the conditions of existence that put him in that boat. People did. Nature didn't. People did. What we build, we can change. Too many people notice our divisions, and they say, well, we can't do it here. We're not Sweden, they'll say. Americans take too much pride in individuality to show solidarity. I beg to differ. We in solidarity look at the picture of a 3-year-old boy, and in solidarity, we cry. We are perfectly capable of caring for others. We're perfectly capable of trusting our own compassion and acting on that compassion. We can be what we choose to be. Do you sleep well? I sleep well if you sleep well. What kind of world could ours be if that were our greeting, the Shana greeting, universally, now and from now on? I don't know about you, but I reject the demagogues who try to tell us that our fates and our duties are not intertwined, not just in our country, but on the planet. I want to ask the leaders, Mr. President, members of Congress, Mr. and Mrs. Mayor, CEO, Board of Trustees, do you sleep well? Others can't, so wake up. We must be a nation that helps first the least fortunate among us. The causes of the causes are not ours to accept, they are ours to change. So start here. Thank you.